that patient had, and I think 7 of those, or 6 or 7 of those, have tested positive so far. So I'd be aware of any patient coming from the Bitterroot. And again, I think this illustrates kind of what's probably going to happen is we'll have small clusters of outbreaks like this, maybe throughout the summer. And then there's a brand new model that's put together by the U of M that is suggesting that maybe those clusters of outbreaks will become more significant in the fall with another surge. So who knows? I don't know that there's any way to predict that right now. So I think the other thing it illustrates is that a lot of these patients are going to present not with the typical respiratory findings. And I think we need to still be doing our universal masking and taking appropriate precautions with patients. So
What was the age of the guy?
Sorry?
What was the age of that guy?
I believe he's in his 50s, but I don't know all the details. I just talked to the intensivist about it and who was taking care of him. He had a fairly high oxygen requirement initially, but now is apparently doing better. So,
Mike, is he sick from COVID stuff, or is he sick from the things that he originally came in from?
I suspect that the COVID illness is what precipitated his DKA, but I don't know that for sure. So that'd be a not uncommon thing to happen. So,
Mike, you may not know, but is he like a single migrant worker that came up, or are the other 30 with the whole bunch that came up?
Well, apparently that group of people have not been doing an exceptionally good job of social distancing. He's from Arizona, I believe, if I remember right, or New Mexico. I can't remember. He's from somewhere south of here. And I think most of the patients who have tested positive are from that community of workers. So let's see. I think a couple interesting things we mentioned just last time about this pediatric multi-system inflammatory syndrome. I tried to find some more information on it, and I basically can't find a ton. It presents, it looks like similar to Kawasaki syndrome. So like mucous membrane inflammation, rashes, and inflammatory stuff. These kids get very sick though. They can develop multi-organ failure and also have some overlapping features with toxic shock syndrome, which is where that's like classically a staphylococcal infection where they develop a immune-mediated response and they slough off big kind of blisters of skin. So if you see something like that, be worried because those kids can be really sick. So there are while I was doing this, there are a number of other associated kind of syndromes that they're identifying with this, and a lot of them are really revolve around hypercoagulability. So a lot of patients presenting with venous blood clots, even arterial blood clots, they suspect that a lot of the illness they develop is from microvascular blood clots that causes the other organ failures. That may also cause a syndrome of kind of altered mental status from microvascular clots in the brain. They're clotting dialysis lines. There have been a number of cases of cavernous sinus thrombosis, which is a clotting syndrome that occurs in the cavernous sinus in the brain. We actually just had one of these, or a venous sinus thrombosis that we decided to test for in the emergency room, which was negative. There's a lot of neurologic complaints that look like maybe associated with this. There have been a number of patients who have a Guillain-Barré-like presentation, which is kind of an ascending paralysis. There's encephalitis, and some really bad encephalitis that they think is associated with this, a hemorrhagic encephalitis. And then again, this kind of vague confusion or encephalopathy is also, looks like they're associated with this illness. So I'm trying to think if there's any other big changes at St. Pat's. Unfortunately, our ability to do rapid tests is being decreased by the system, so that could potentially impact testing time for EMS, although anyone who's critically ill coming in that needs airway management is still going to get rapid testing.
Mike, why is that? What's the change there that's causing that?
The system looks at prevalence because the allocation of those tests is based on system level stuff. And since our prevalence is so low right now, they're going to move that to another part of the system that's doing more testing. So let's see. Our triage in the front of the emergency room, we've gone away from the separate clean and dirty. I'm sorry, I'm supposed to say red and green triage. So red and green triage has kind of gone away. So we just have separate triage rooms for patients who are possibles versus those who aren't. We still have no ED visitor policy except for pediatric patients and then patients who are significantly altered. The gift shop is going to open at the hospital. Get ready. I know you're all excited for that. The clinics are going to start seeing a lot more patients. I think that's, so that could potentially impact us as well, because I suspect that the clinic's threshold for sending someone to the emergency room is going to be lower right now. So I would be aware of that. Other EMS issues. Does anyone have any issues that have come up? Crickets.
I got Jeff here. You got a question, Jeff?
Yeah.
So we had a crew that transported a patient, met the salmon crew, and then took him up to the ICU yesterday morning. And what was in question was there was a delay of information to our crews. It sounds like salmon may have communicated with the ICU, but did not communicate with either the staff in the rig from salmon or to our staff at all that they were going to rule this person out.
So
sounds like to me the person didn't have COVID. I talked to Lance this morning. He tested negative, it sounds like. But the point is there's some communication there. And I don't know if that's anything that would play into your role to say, how do we screen that better? Because our crew wasn't PP'd up. Now, we fogged our ambulance, which that's whatever it is, but our crews were susceptible if that would have been real. I mean, they had masks on and stuff like that. So the risk is pretty low, but nevertheless.
yeah, I think, there are a number of issues going on. One is that, any critically ill patient who's going to get airway managed or be on kind of, non-invasive ventilation is going to get tested right now.
Okay.
Anyone who's going to need a urgent procedure or emergent procedure is also going to get tested. So those groups of patients, while we may not do, like the full cohorting and isolation in the emergency room, are still going to get tested. So
Okay.
we're treating all the, acute respiratory failure patients as could be positive right now. So that's using N95. But some of these other patients who are going for kind of emergent surgery for, say, a bowel obstruction would not, they would not get that kind of level of isolation. So I think the communication just needs to be really good. And we should, if we don't know, we shouldn't just assume, we need to ask. And so some of that's probably on the doctors who arrange the transfer. Some of that's probably on the salmon crew. And, I guess if there's concern, we just need to call.
Yeah.
So
I think Bob did talk to the crew at Salmon, meaning the hospital.
yeah.
I wonder what might behoove us if they're coming to a higher level of care and you guys have a different thought process. I wonder if it wouldn't behoove us to say, all right, whatever it is, we're going to call the receiving hospital and ask what their plan of action is that might dictate what we do in the plan of action when we see that patient.
Yeah, I think that's really reasonable. So.
Jeff, Bob did ask that specifically, and they said no. So they pretty much were not very truthful about it. Our crews found out when they met up.
Yeah, that's what I'm saying. But I think if we would have called the ICU and say, hey, where you're going to get this patient, what is it that you guys are seeing based on the report from Salmon, and how should we react to that? Because they acted like it was a COVID rule out. If we would have known that, our crews would have been gowned up and specifically for that.
Yes, I did. I spoke with the receiving hospital and I spoke with the crew specifically addressing COVID concerns, complaints, history, because his complaint was not just GI bleed, but respiratory as well. And then I don't know if are we not giving ICU direct admit patients in the Sally Port anymore? We were told that the COVID concerned patients, we were swapping in the Sally Port. We weren't going to parade them through the entire ER. I put him in a mask for good measure just because we're coming into the hospital and that's kind of the standard that we do local, but he was not even masked in the back of their truck.
Yeah, I mean, I think, well, I'm really in favor of the universal masking thing right now, especially in the healthcare setting for sure. And I think there's good evidence for that. So we need to be doing that. So that's great that we got that mask on that patient right away. I think there's going to be miscommunication.
Melissa, that you did anything incorrect. What I'm asking is, we take, Bob or I or John or somebody's going to take these calls. I'm wondering if we shouldn't be calling the ICUs to give you guys some more comment about what you're going to do. What you did, it was absolutely the right thing. Was that I'm make sure that you're clear on that. But I think maybe we need to be calling and talking to the receipt and seeing what avenue they're going to go. That may dictate what we do.
Hey, and Jeff, there are non-messy people on this call, so we need to discuss that privately.
Okay.
Let's move off of that.
Okay.
Can we address are we doing that in the Sally Port? Are we going to move ICU patients in the Sally Port? Can we address that?
My understanding is that if it's an ICU patient, we're still supposed to have them come meet them in the ambulance bay. And I haven't heard that that's changed, so.
The ICU staff Wednesday morning thought that maybe that was not in progress anymore. That was different, and that's why I bring it up.
I'll double check today. I work tonight, so I'll find out. But my understanding was that, especially if it's someone they think it might be a positive, they're going to do all that. If it's someone they're going to rule out, they're going to do all that, is what I thought. So,
okay.
But I'll double check and I'll get that to Dave. So, McAvoy, I'll get that to McAvoy.
Mike or Melissa, you got any other questions about that?
I see that not all agencies are masking anymore routinely. Is that what we're doing now, or?
No, we should be doing masking.
Okay.
So I will say that I have had a lot of questions recently about taking hydroxychloroquine. If there's any thoughts out there, I do not think it is a good idea to take hydroxychloroquine prophylactically. There's no evidence for that. And it does have side effects. I actually took it for malaria, I think, a long time ago. I think I took that. Yeah, I took it for some kind of post-exposure deal where I took it after I got back from a trip. And I didn't have any side effects, thankfully, but other than I think it would cause some insomnia, but it has a lot of side effects, so it's not a benign medicine. And looking at the data that's out there so far, there has not been really even an association, let alone any kind of causal relationship with an improved outcome. And there's some studies that are showing trends towards worse outcomes with taking it, but that may be biased because they're giving it to the sickest patients. So if people ask you about hydroxychloroquine right now, say that you would not recommend it and that they need to talk to their doctor, but there's not good evidence for that right now. So. John, did you have anything?
Me, John, or John?
Oh, John Gilday, sorry.
Other than with the multi-system inflammatory syndrome in children, that like you said, when I did my search on other symptoms and issues with that or findings with that, I didn't find much more than what you spoke about. However, they did find there was a couple cases where they did have some changes in the hands that were consistent with Chilblain's syndrome. So if you don't know what that is, you can look that up under images in Google to see what that looks like. It's usually kind of sometimes paling of the hands, and then the fingers themselves will get kind of hyperemic, as well as, remember, with Kawasaki's strawberry tongue. And then they've also been some kids where almost the sole presentation was conjunctivitis. So just be, watching out for those things as well. And I agree with the hydroxychloroquine. I mean, unless you're under a direct physician's close, a watchful eye of what they're doing, monitoring you, especially if you have other, medical issues going on, it's just, there's no evidence to support taking that. So, that should really be discouraged in anybody. Other than that, I got nothing.
I got a couple follow-up questions just about CDC screening. Are there any new things that they put out about signs and symptoms that we should be looking for that are other than what we just discussed?
I think still using the expanded symptoms right now. The fever, cough, shortness of breath is the, kind of I guess the classic ones, but GI symptoms, chills and shaking without fever, sore throat, loss of taste and smell, all those other ones we need to consider as well. And we should probably ask specifically. So
Yeah,
I think that some of the like this case in Hamilton, I don't know, but I can imagine that someone presents with DKA, you may not go through all those other symptoms as thoroughly as you should have, and then you end up with a cluster of cases. So,
just a couple of questions. So, just in terms of what's considered to be a hotspot now, or when we're asking, or 911 is asking, what is that at this point?
I almost don't think it's worth trying to figure that out anymore. It's just too difficult. I think anyone who's traveled from another area or from an area locally, like, down in Hamilton now, is what we should think about. But, keeping some up-to-date list of cities where cases are on the rise and not, it's just going to be too complex right now. So.
Okay. And Dave Smith, maybe you can help with this. Anything new with 911 dispatch, or Mike with dispatching, the way they're asking questions, or what we're going to receive on our printout, digitally?
Nothing new that I'm aware of, Dave.
Okay. Great. Anybody else have any questions? All right, thanks everybody. Thanks for taking the time. I'll post these to our YouTube page again. I appreciate the docs coming in and giving their expertise. Right, take care.
And I'll try and get that information about direct admits to the ICU to Dave McAvoy. So.
Thanks, Mike.
All right, thanks guys.
Thanks, John.
Thanks.
I missed this part of it.